thanks very much for inviting me here to speak. And I'd like to stress I'm speaking on behalf of Dr. Heather Marie Schmidt, who couldn't make it today. And that's very unfortunate because I'm sure she would be much more eloquent at giving this talk on long-acting PrEP in low and middle income countries, but I will do my very best to represent her. Just a bit of background from WHO's perspective. Here you can see the timeline on recommendations on PrEP, starting even before 2015 with specific conditional recommendations of offering oral PrEP to specific populations. And then in 2015, there was a recommendation to offer oral PrEP to all individuals at substantial risk of HIV. More recently, we can see here those two recommendations in 2021 and 2022 on long-acting PrEP methods that will be the focus of today. In 2021, WHO recommended to offer the PIVIN vagina ring to cisgender women at substantial risk of HIV. And in 2022, just last month, the recommendation was released to offer long-acting injectable cabotegravir as an additional prevention choice for people at substantial risk. You can see on the slide that there has been quite a substantial increase in PrEP use globally since those original recommendations from WHO in 2015 and earlier. On the right-hand side, you can see the scale up to nearly 1.8 million PrEP users last year, despite significant disruptions by COVID-19. But what you can also see here is that that scale up recently has really been concentrated in the African region. And more importantly here, if you put the scale up into perspective, you can see that PrEP uptake is indeed still quite slow here, specifically for the Asia-Pacific region. Uptake in many countries is limited. And on the bottom right-hand side, you can see a graph that shows the current PrEP use in relation to those red dots that are the targets for 2025. And you can really see how far away in many regions we are from reaching those targets. Again, specifically for the Asia-Pacific region, you can see how PrEP is indeed needed to fill the prevention gaps among key populations that are heavily affected by HIV. In the middle, you can see how most infections occur in this region among key populations and their partners. And on the right-hand side, you can see significant gaps in reaching those key populations with prevention interventions. So why are we talking about new PrEP options, and what are new PrEP options? Offer an additional choice and thereby increase demand, uptake, and effective use. We know that oral PrEP is highly efficacious and has been around for a while, but there's still limited coverage. A substantial proportion of people who are offered oral PrEP will decline it, discontinue relatively soon after initiation, even if they do start or do not use it effectively. So additional long-acting options offers an additional choice because people have diverse preferences. So offering this additional choice may be more aligned with people's preferences and thereby increase demand and improve uptake and also use. Let's talk briefly through the two WHO recommended long-acting PrEP option. As I mentioned, the PIVIN vagina ring has been recommended by WHO in 2021. It has now been approved in several countries in Southern and Eastern Africa, and I'm pending more approval in that region. And the benefits are really that it's women-controlled because it's self-inserted or can be inserted with assistance. It offers continuous protection for 28 days if left in place. So it is indeed a long-acting method, and protection is achieved very quickly, 24 hours after insertion. It is very safe. There are very rarely any adverse events. There's a low risk of drug resistance because the drug really acts locally. It is a very simple method. So there could be simple models of delivery. For example, initiating the PIVIN vagina ring with a self-test for HIV. It's very discreet. You don't have pill bottles as you have for oral PrEP. There are no effects on contraceptive efficacy, and values and preferences research indicates that indeed some proportion of women prefer this method, and particularly it's quite acceptable among people who have used this method compared to those who haven't. There are some potential drawbacks for the ring, including potentially a lower effectiveness or efficacy than oral PrEP. We will not know exactly how efficacious this product is, but it's likely that it is lower than oral PrEP. It may not be culturally, socially acceptable in all population. And at current pricing, it is likely more expensive than oral PrEP. But again, I mentioned that it's quite simple to deliver, so there are fewer health system resources needed to deliver this method. With regard to long-acting injectable cabotegravir, this is an injection given every 2 months. The first 2 injections are 4 weeks apart. This has received FDA approval for use in the US at the end of 2021. And as I said last month, WHO released a recommendation to offer it as an additional prevention choice. This is really a consequence of 2 large-scale randomized controlled trials that showed that the CAP-LA is highly efficacious. In a pooled analysis of data from these 2 trials, it was found that this intervention is associated with an 80% relative risk reduction, so an 80% lower risk of HIV acquisition compared to oral PrEP, which is really to do with the fact that it's long-acting and it's not dependent on adherence to pill taking. And that HIV incidence reduction is sustained after the trials have been unblinded, and very importantly, particularly in the Asia-Pacific region, very recent data released just at the AIDS conference a week ago showed that there's no effect of gender-affirming hormones among transgender women on the efficacy of this product. So it is highly efficacious. It is also acceptable across populations. We did a systematic review on the values and preferences among users that were largely hypothetical. It's a product that's not widely available yet, but if you ask people hypothetically, what kind of PrEP product would they like, large proportion tend to say injectable PrEP is a good option for them. And it is also acceptable by providers. We did a survey of over 1,000 PrEP providers, and those that have heard of it were quite supportive, but it's also noteworthy that only 50% of PrEP providers have heard of CAP-LA. So a lot of kind of training and awareness raising is necessary for implementing this intervention. But let's talk a bit about some of the evidence gaps and challenges with CAP-LA. There is indeed a lack of real-world data outside of trial settings and for certain population geographies. There are challenges with HIV testing and drug resistance, and I will go more into that in a minute. The extent of drug resistance and the potential cross-resistance to other drugs of the INSTI class, notably dolutegravir, which is recommended first-line treatment, is unclear. There are lack of data for safety in pregnancy and breastfeeding. There are lack of clarity on cost effectiveness. There is variability of the pharmacokinetics we've seen in the trials when we compare cisgender men and cisgender women. We don't really know yet how to maintain adherence to this product in a real life setting and how to overcome some of the access barriers. And then in reality, how to support the switching between PrEP products from CAP to PrEP to other PrEP options, and how to stop CAP-LA has not been, again, studied outside of a trial setting. And all of this in detail is outlined in the guidelines that WHO has released last month. So just briefly going into the HIV testing and drug resistant issue, with a really important not just for the implementation of this product in low and middle income settings, but also in high income settings. WHO is noting in its guidelines that programs should select a testing strategy and algorithm that promotes access to CAP-LA among those who would benefit most. And programs can use a current national HIV testing strategy or algorithm as per WHO testing recommendations. So this is usually a combination of rapid diagnostic tests. This is important because some countries may choose to include NAT testing or RNA testing in addition to the national algorithm for CAP-LA, particularly at initiation. And the reason here is that there has been some studies that have shown that potentially some of the drug resistance associated with CAP use could have been potentially prevented if NAT or RNA testing had been used instead of rapid diagnostic test. But it is important when NAT is used to have the necessary assays, resources, and regulatory approvals, and a clear testing strategy to resolve any discrepant results and establishing HIV infection before initiating lifelong RT. And that's quite critical because we have also seen from the trials that there are discrepant results when NAT is used in hindsight and rapid diagnostic tests. So how to actually diagnose a person with HIV is challenging. What we are noting in our guidelines is that, yes, drug resistance is a concern, but the number of cases that have developed drug resistance in the trials is very small. NAT might prevent a very small number of cases of drug resistance, but countries need indeed to consider the feasibility of NAT testing. I said NAT testing has often not, many NAT don't have regulatory approval for HIV diagnosis in adults. They're expensive and not widely available. So if countries require NAT testing for CAP-LA implementation, that would severely limit the delivery of this option. And there are also uncertainties in how far these drug resistance mutations observed in the trials actually impact subsequent first-line RT efficacy. Just rushing over some other gaps in the evidence that are quite important for cabotegravir, namely, I said there's limited data for safety in pregnancy and breastfeeding, although so far there's no indication that it's not safe during pregnancy, but here indeed more implementation science is needed. Similarly, for young people under the age of 18, they were excluded from the trials and there are only some small studies ongoing, so we need more experience with reaching this small population and the potentially additional support they need. And then keep population more widely. Yes, the HPTN 083 and 084 studies have provided PrEP to MSM, transgender women and cisgender women, but studies did not include people who inject drugs or sex workers, and implementation science urgently needed for these populations. And all of this, just bringing it all together, is about delivering choice. As I mentioned, users have diverse preferences and needs, which may change over time. And this is now a great time because we have multiple PrEP options and people interested in PrEP should be provided information on available options, their relative efficacy and safety, and counseled to make informed decisions regarding what's best option for them. And for all of that, involving communities at all stages is critical, including for awareness, raising, demand creation, and delivery. Cost and cost effectiveness is an important issue, and there's huge uncertainty here how the costs, how much these products will cost when actually implemented at scale, and what the cost effectiveness is. At higher efficacy of CAP-LA may justify a slightly higher price, but preliminary results from cost effectiveness studies suggest that CAP-LA needs to be priced similarly to oral PrEP or slightly above to reach cost effectiveness. But also cost effectiveness is not the only consideration for program implementation. Finally, all of this is part of the broader agenda to make services more differentiated, adapting services to the person who could benefit from PrEP and their communities, to their needs and preferences, and so to make services more acceptable and thereby improve uptake, persistence, and effective use. And indeed, within this broader agenda, there's a certain risk here of remedicalizing PrEP. We have seen in recent times this movement to demedicalize PrEP, making it more accessible. And now with CAP, some of that could be reversed. So that's really important when we think about delivery models. And I just note here, recently published technical brief by WHO on differentiated and simplified PrEP. And finally, I'm just noting that, of course, this is a diagram that exemplifies the global targets adopted by the United Nations General Assembly for ending AIDS by 2030. And part of that here, if you look on the left-hand side, is about creating an enabling environment by removing societal and legal impediments. And none of these new PrEP products can reach those who could benefit from it if we don't remove barriers like stigma and discrimination. So with that, I end. Thank you very much. I thank everyone who contributed to this presentation, in particular Heather Marie Schmidt. As said, she's a true expert of PrEP in the Asia-Pacific region. I encourage you to reach out to her. I'm just advertising here that we, on the 25th of August, we are doing a webinar on simplified and differentiated PrEP services. So I encourage you to check out the Global PrEP Network website. And in October, November, we are planning 2 webinars on CAP-LA. With that, I thank you.